HRA is earlier than your CS, right? I mean, that is very, very unlikely because the tachycardias are all starting from bottom, and so your catheters CS and HIS are closer to the bottom, and they should, the inferior catheter should be early. But your HIS A is early, but your HRA is early, and then only your CS is coming. What does that tell you? So if that is the case, you have to consider right-sided accessory pathway in the mind, because it could be that it broke out on the right, went to the HIS catheter and the HRA, and then reached the CS catheter. So you have to consider that alternative, that you could be dealing with a right-sided accessory pathway. And when you put a BPD series, you will see HRA is clearly beating the CS, consistent with a right-sided accessory pathway. The HRA should be in the high right atrium. It should not be at the bottom. The catheter should be in the right location for you to interpret. So this was the prior. We were doing 2 right-sided accessory pathways today. If you put a halo catheter, it brackets you. Like this is later. Sorry, let me use the mouse. Later. These 2 are early. Later. So that's what's called bracketing. Meaning you know the real pathway should be between these 2, right? These are the 2 earliest electrograms in the right atrium. So we should be able to concentrate our mapping in that area rather than going everywhere. This is the advantage of putting a halo catheter for right-sided mapping. And I'll show you how it will look. This is a halo catheter, you see this? So it spans the whole distance, and I know the pathway is right here between these 2, and this is exactly where I put the catheter with LSR2. What's the question?
Focusing with that.
Okay.
People that if they have any questions, they can interpret.
Yeah, you see, please feel free to stop me at any time. So this is the same problem we encountered with Dr. Rita today. We had a left lateral pathway near the appendage, and the CS catheter was finished here. But we went above it, going too medial, it was late. When you come closer to it, it was getting early, but it was a little bit above the tip of the CS distal when you base. And you can see here, CS is here, CS distal, but ablation is much earlier, the A. So you need to be able to map the whole circle, like up from here to here, to know the areas that CS catheter is not already there. This is failure to bracket is a problem. If you advance the catheter, it'll really map the whole thing. So here is a patient of the left lateral pathway, CS12, going like this, right? And when I advance the CS catheter, you see how it brackets? Now it's getting later again. Later, early, and later. So now you're bracketing. So you know that you have to map between 5-6 to 1-2, somewhere near 3-4. The advantage of pushing the CS catheter farther out, which is what we had a patient with left lateral pathway today, and we said, if you advance the catheter, we'll be able to bracket. But even after that, we couldn't bracket. That's a different issue. But you should try to bracket it by advancing the CS catheter all the way out. All right, so here is a tachycardia, which looks like a V on A or A on B or something. Looks like AV node reentry. So now you're getting confused whether this is AVNRT or this is something else. But your HRA is earlier than HIS A, is earlier than CS19 and 20. So you're always concerned, am I fooled by an atrial tachycardia with long PR? Or it is AV node reentry with pseudo R2P interval. I'm looking at the P wave morphology, it is sticking to the QRS. which I've been preaching that it is probably AV node reentry. But HRA being early is a tip-off. HRA earlier than CSA tells you that it's not coming from the bottom. So now I have to be careful. So I'm trying to measure some of the intervals to see what is driving this tachycardia. A to A interval is 323, right? A to A is 323 here. A to A is 323 here. Okay? Now I'm measuring the A to his interval. AH is 159, AH is 201, and the tachycardia doesn't change. Right? You understand the A to his interval? Here's your A. This is tachycardia cycle length. You agree this is the his A? The yellow catheter is the his catheter. A, and here's your his. A, onset of the A to the his, 159. Onset of the A to the his, 201. So you have a 42 millisecond increase. But A to A doesn't care what the A to his is doing. That, and also you can see that the QRS is being dropped. And that means the AV node is not necessary for sustaining this tachycardia. That means the only tachycardia where AV node independent tachycardia is atrial tachycardia. So simply by measuring the intervals, I'm able to figure out what type of tachycardia am I dealing with. So here is a tachycardia where his onset of his to the onset of A, onset of his to the onset of A. So it is 158, 190. So his to A is changing. You can see the QRS to A is longer here. But the tachycardia is fixed, 440, 440. So when your HA is changing, but the tachycardia ignores it, that rules out AV NRT. So it has to be atrium is independent of what's happening at the level of the AV node or the QRS. So that is again suggestive of an atrial tachycardia. So here's typical AA predicts cycle length change. So here we have 441 tachycardia cycle length, 441 tachycardia cycle length. A to A is predicting what the his to his is going to do, not the his to his to A to A. So that is suggestive of atrial tachycardia. So, Spooty, you answered this before. Do you have a classmate? Do you have? Sorry, what's your name? Sambhavi? What do you think here? Let me walk you through this. Left bundle base block, narrow QRS, B to A, 150, B to A, 87. Tachycardia is slower. Tachycardia is faster when the QRS is narrow.
When the tachycardia is slower, you will be and that is not faster.
Suggestion of what?
Maybe
Left-sided accessory pathway be needed, ORT or tachycardia. Excellent. So always look for bundle branch blocks. Now, when you have a left bundle branch block, it is a lot, because you're going through the right bundle to come back up. Your PPI TCL on the right side when you pace from the right ventricle will be ultra sharp, because now right ventricle is part of the second. You see? Whereas when you are pacing the right ventricle when it is using the left bundle, you are not part of the circuit. And therefore your PPI TCL may be a little bit longer. But when you have left bundle, you put a VPD or you put a P or pace from the RV, you immediately get into the tachycardia. Because your right bundle is part of the tachycardia cycle. So you should be able to get in very quickly. Here again, left bundle branch block. switching to narrow QRS, 290 millisecond tachycardia cycle length, shortens to 236. Very fast, classic Kumal's phenomenon where you have ipsilateral bundle branch block. If you have this, you don't need to do anything else. You have a left-sided pattern. But what can happen in what condition? You can have a left bundle branch block and you are having a VA change, but your tachycardia cycle length does not change. When will that occur? What? No, this is aberrancy. So even though your VA time increases, your AH interval can shorten or longer, and so the tachycardia cycling may not fluctuate. So there's a caveat, small caveat, although invariably the left bundle lengthening of the VA is not going to be exactly shortened by the AH. There could be a dissociation. But if it does exactly the same amount, whatever this lengthens, that shortens exactly the same amount, your tachycardia cycling will not change. So even though you go back to the A, you have to come back to the V through the AH, his A to his interval. And that lengthens or shortens, that can mess up this whole finding of left bundle branch block, always slowing down the tachycardia. You could have an AH lengthening correspondingly when you're narrow, and that can make you sweat. So bundle branch block increases the VA interval. So here it is V1, it is a long VA, and when you're narrow QRS, short VA interval, you can see the V to A, onset of the V to the onset of the A is what you should measure. Onset of the V to the onset of the A in the CS, and you see how long and short, characteristic of a left-sided accessory pathway-mediated tachycardia. Now this is what I drew there. You can see that in a typical tachycardia, it conducts through this. All accessory pathways are bridging across the mitral annulus or tricuspid annulus. So it comes back up through the solid line. But when you have a bundle branch block, like a left bundle for ipsilateral, then you have to go through the right bundle, go to the apex of the heart, and then come back. This extra distance adds extra time, which slows down the VA interval, which slows down the tachycardia cycle length. On the other hand, here is a patient with a left ipsilateral bundle, but VA interval is 51. Patient develops a right bundle branch block. Everybody can recognize the last 3 weeks, right bundle, right? This is V1, negative QRS. Now RSR prime, RSR prime, RSR prime. So right bundle. But there is no change in VA interval because left bundle branch block, left-sided accessory pathway would carry us to what happens to the right side, right? So that is not affected because you are now dealing with a contralateral bundle branch block. Here is a very long RTP interval. Normally we'll think it's atrial tachycardia, but it is 120 milliseconds, which kind of puts you into the ballpark of PJRT. And then you can see the P wave is very wide. And that tells you sequential activation of atrium, which means it is not in the anteroseptum, but posterior or infroseptum. And therefore, this, you can see how wide the P wave is. And it is occurring in the last third of the or interval, characteristic of PJRT. And this particular patient was ablated right here. We talked about this. How do you know that this is pre-excited atrial fibrillation? Who's doing MD or DIP-MD medicine? You're a biology fellow? What is your name, sir? Deepak? What is pre-excited atrial fibrillation? Okay, varying aura interval and white QRS complex, and due to what? Atrial fibrillation with accessory pathway conduction, right? So here, very good. So here you're seeing it is conducting through the accessory pathway, here it is conducting through the AV node, and here it is conducting back up here AV node. So you can see that it is all over the place, the R2R interval. And whenever you come too quickly, anytime a pathway conducts, it comes back to conceal the AV node. So allowing more pathway conduction. If the AV node conducts, it goes back and conceals in the pathway, more AV node conduction. But in AFib, we don't know which pulse is going to hit which one of them quick. And so, what is the drug of choice to treat this? Very good. Procainamide or ibutylite? Can I give amiodarone? Why? Intravenously, it's a beta blocker acutely. It may have class 3 effects 3 weeks down the road, but acutely it's a beta blocker. So you really can't use this. So the drug of choice is procainamide or ibutylite. You cannot use amiodarone intravenous acutely. So we talked about why antroseptum is contiguous. So P wave that occurs here will go immediately, but postroseptum is a triangular space with lymphatics, coronary sinus, right coronary artery. So really, it is not continuous at all. That's why postroseptal P waves are wider compared to antroseptal atrial electrogram. A tachycardia terminating with the QRS. What does that tell you? Here is a tachycardia that goes on, breaks with the QRS. No. Atrial tach. If there is no A and there is no tachycardia, AVNRT or AVRT or ORT, but it ends with a QRS because the atrium stopped firing here, and therefore there is no tachycardia, and that's why it is atrial tach. Now the other thing is, an astute observer would have seen it is slowing down in cycle length. You can see it is faster, slower, slower, and then it breaks. That's called cooling down phenomenon. Warm up and cool down are characteristic of atrial tachycardia. So when you speed up and slow down, AVNRT, ORT, they don't warm up and slow down. They abruptly terminate. So the fact that they warm up and cool down are characteristic of automatic atrial tachycardia. It is not suggestive of AVNRT or ORT. One thing when we ablate, we always look for whether the CS near field is early and far field like a P wave is early. Your CS near field is early, you may ablate the pathway in the CS and not in the left atrium. So we look for which one of the electrogram is earlier, because the CS is a composite of both CS muscle coat and the far field LA together, because the electrode sees both and it puts them both on superimposed on each other. But if your sharp near field is early and your far field atrium is late, then you have a break in the CS. So we always said that if you get a pathway potential and a blade, for example, QRS, pathway potential, a His-like structure, and A. You have, here is a His is in front of the QRS. This is after the QRS, pathway potential. And if you have pathway potential on a plate, one burn, the tachycardia will terminate. If you have no pathway potential, you will be ablating a lot. And this was pathway potential. And this is Sonny Jackman's paper. If one people can read this. If you have an isolated pathway potential, one burn. No isolated pathway potential, you have to burn a lot more to produce a block. So here is a classic QRS pathway potential A and QRS pathway potential A. So a very high frequency signal is pathway potential between the V and A. Spontaneous PVC advances the A, right? So you have a tachycardia, you have a PVC that happens to occur right when the His is already inscribed. And the A got pulled in, 355, 322. So when your PVC is occurring, the His is inscribed, PVC is occurring in the ventricle. The His is already activated antegrade by the tachycardia. There's no way it can go through the His. If it is pulling the A, it must go through some other structure other than the His AV node. So that means that it must be an accessory pathway. Accessory pathway present is true. Is the accessory pathway integral to the tachycardia? Meaning, is the tachycardia caused by the accessory pathway? For that, you need to measure His to His, His to His, and His to His. If this His to His is exactly the same as this His to His, then you could have a pathway, but the tachycardia is AV node re-entry. Because even though you have pulled the A, you've not altered the tachycardia. That indicates the reset is measured at the level of the His. And when your reset is not occurring at the level of the His, you know there is no way this can pull the A when the His is already inscribed. So there is a pathway, but the pathway is not integral or causing the tachycardia per se. So you are now maybe dealing with a bystander accessory pathway. Ah. Did you guys listen to the earlier portion or no? Oh, okay. No problem. We'll talk about maneuvers in the EP lab. So we covered all the baseline observations. So let us summarize what all we covered very quickly for their benefit. And also Dr. Garg can comment also. So we talked about all these fast pathway, slow pathway, and all these 2-for-1 response. Then we talked about how the tachycardia goes up to the fast here because His A is early. Then we talked about how it is going through the slow pathway because the CS is early. And this is a long RP tachycardia, suggestive of fast, slow AV node reentry, not slow, fast AV node reentry. Yeah. Yeah. Then we have typical A to H jump to start the tachycardia. VA septal, VA interval is short. We covered this. If you have a left bundle bench block, VA interval is lengthening. For ipsila to bundle bench block tachycardia, bundle bench it widens the VA interval and slows the tachycardia. We talked about 2-for-1 AVNRT. 95% of the block is at the infra-His, and a PVC will unmask it and make it 1-to-1 tachycardia. And then we talked about septal VA interval. Then we talked AV node independence. Here it is blocked, but tachycardia could care less. So that is suggestive of atrial tachycardia. Then we talked about HRA beating the CSA. That means a right-sided accessory pathway should always be considered. Even though His A is beating the HRA, you have to consider a right-sided accessory pathway. If you put an atrial extra stimulus, HRA is really early, ventricular extra stimulus. We talked about bracketing using the halo catheter, like how it is late here, it's late there, it's in between, it's early. And this was how we put the halo catheter to bracket a right-sided pathway so you can focus on the area. I think we should get them a halo catheter. There are so many right-sided. So here's a CS distal is early, but my God, ablation is even earlier because your CS is not all the way advanced. Bracketing using the CS catheter. Here is the CS is late. CS12 is late, early, but only when you advance the CS catheter further, you bracket it. So you have to advance it to bracket it. You can't just leave it like this, or this is early, I'm going to map it. If you advance it, you bracket whichever is the earliest electrogram. We talked about this because the AV node, here is the tachycardia, same cycle length, 323, 323. A to his interval A to his 159, A to his 201. AH fluctuation does not affect the tachycardia. So we said this is independent of the AV node. What is independent of the AV node? The AAT. We could care less what the AH is doing. Talked about HA independence, which is also HA does not change tachycardia cycling, that is AVNRT, that excludes AVNRT. Now AA predicts cycling change, meaning here's your ADA is 441. That changes the his to his to 441. ADA changes before his to his changes, characteristic of atrial tachycardia. Whereas his changes before AA, that suggests to AVNRT or ORT. We talked extensively about bundle branch blocks and tachycardia cycle length. Here is a left bundle branch, slow tachycardia, fast narrow QRS, faster cycle length. VA cycle length is 150, VA 87, suggestive of ipsilateral bundle branch mediated mean left-sided accessory path. Yeah, same thing. Left bundle, slower tachycardia, narrow QRS, faster tachycardia. You don't need any additional maneuver if this occurs. But we touched on the caveat that your AV node can exactly decrement the same amount and keep the tachycardia at the same cycle length. So while this occurs most of the time, but not all the time. But one thing we know, we talked about prior may find it useful. We have an ipsilateral bundle branch block. Now the right bundle is part of the tachycardia. Your PPI TCL from the right side will be short because the right bundle is not a part of the tachycardia. Similarly, a PVC on his will instantaneously advance a left lateral pathway, whereas it won't do it if you have a left bundle conducting because it now has an intraventricular conduction. So we talked about that bundle branch block increasing. We talked about this one, what's the explanation? The solid line tells you how the bundle branch. Now, if you block here, you have to go through the right bundle to the apex to come. The path length increase leads to the VA increase. Then, if you have a contralateral bundle, here's a right bundle in the left-sided pathway. It doesn't do anything to the. There's classic Kumel's phenomenon. We talked about wide P waves being from the posterior and that's PJRT in this particular patient. We talked about pre-excited atrial fibrillation, why amiodarone should not be given, procainamide and ibutylite. This is a posterior area is not contiguous because of CS, right coronary artery, lymphatics, and fat. Anteroseptum is continuous. We talked about if the tachycardia terminates with a V, it's atrial tachycardia. The tachycardia terminates with an A, it's AVNRT or ORT. We talked about CS near field versus far field. If your CS near field is early in an accessory pathway, your ablation should be inside the CS, not in the airway. If your far field is early, then you go into the left atrium. Then we talked about pathway potentials. This is a B, pathway potential A. It's not a HIS, it's at the back of the QRS. So this is a classic high frequency pathway potential. I think your lab needs to be grounded a little bit better to see this. And so if you have a pathway potential, all you need is one burn. If you don't have a pathway potential, or we're guessing like the case that we did with Dr. Prayar, because we know A is early, but we can't see the fidelity of the electrograms. We may have to burn them longer, deeper, and so on. I mean, you're going to be successful at the end. Spontaneous PVC pulls in the PA signal. Here is the AA is 355. A PVC that falls on the His is pulling in the A at 322. So a pathway is present because you cannot get back to the A when the His is already inside. The only way to get back is through an accessory path. But in order to know the pathway is integral to the tachycardia, the subsequent His needs to be pulled in. If your His stays rock steady, you could have a bystander pathway with alien artery. So you cannot really exclude that. So that's where we stopped. Now we're going to start with maneuvers. So these are all baseline observations. We never disturbed the tachycardia ourselves. We just simply observed what is happening and deduced what is the possibility. We don't want to disturb the tachycardia yet. So all